Hello, everyone. This is Dr. Carmen Pugliafito, and I'm happy to have here today Dr. Roger Goldberg, who is with Bay Area Retina Associates and also on the faculty of the California Pacific Medical Center. Roger, welcome to Retina Synthesis.
Great to be here. Thanks for having me here, Carmen.
We're going to talk today about an important topic, which is intravitreal dosing of medications. And you presented a paper at the Academy, which discussed some dosing errors that occurred. But what are the general considerations in terms of dosing in intravitreal injections for anti-VEGF therapy?
Well, first of all, intravitreal injections it's a great modality, a great way to deliver therapeutics to the retina. It's extremely well tolerated, despite kind of patients' initial squeamishness about the thought of getting a needle in the eye. It's very safe, very well tolerated, and highly effective because we can deliver what's a relatively large dose into the eye in order to treat, the target disease, but very little of it gets out systemically. So it's a great modality. But of course, we want to inject an amount that we know, because consistency is important to kind of evaluating the effect of any medication. And so most of the anti-VEGF drugs that we're using, we're injecting 0.05 milliliters or 50 microliters is the standard dose, and that includes off-label Avastin or bevacizumab and on-label ranibizumab, which is Lucentis, or Aflibercept, which is Eylea, and brolucizumab, actually, which is less commonly used, although the newest agent is also a 50 microliter dose. And so, I think I actually remember a lecture many, many years ago when you were talking about OCT as a VEGF-o-meter. And so sometimes when you saw a patient who wasn't responding well, and this is back when we used to draw up medicine in a vial, I think sometimes people would cheat a little bit and in a controlled way, give a little bit of extra medication beyond that 50 microliter dose in order to try to maybe get an enhanced effect of whatever medication they were injecting. And intravitreal injections, we now do about 10 million of them a year in the United States. So very common procedure. Vast majority of these are done by retina specialists to treat retinal diseases. And it's been a dramatic growth in these. And to prepare the medicine from a vial, Lucentis and Eylea originally came packaged in a glass vial, and we would take a 19-gauge filter needle and uncap it, sterilize the rubber stopper, screw on a 19-gauge filter needle onto the 1 cc syringe. We draw up the medicine through the 19-gauge filter needle into this transfer syringe, and then we would switch needles to a 30-gauge needle, expel the extra air and set the right dose and inject it. But several studies actually have looked at how much time it takes to do to draw up the medicine, and it's about a minute to draw it up. And so you can imagine, if all 10 million of those injections were requiring the individual steps to draw the medicine out of a glass vial, well, that's 10 million minutes. And the market leader, at least by dollars, is Eylea or Aflibercept. Of that 10 million, about 2.5 million injections are Eylea. So 2.5 million minutes to draw up 2.5 million doses of Eylea that's actually about 5 years of time, of someone's time, of many people's time to draw up the medication. So it was with great, I think, kind of enthusiasm that Regeneron launched the Eylea prefilled syringe, the Aflibercept prefilled syringe in 2019. It was approved in August of 2019. In Europe, it was approved in April of 2020. The Eylea or Aflibercept prefilled syringe is a 1 milliliter glass syringe. It's got a baked on silicone lubricant. There's no transfer syringe involved. There's no 19 gauge filter needle. And prefilled syringes have been broadly adopted. In the United States, the ranibizumab or Lucentis prefilled syringe, which was launched about 2 years before the Eylea syringe, that's about 98% of total ranibizumab use in the US is in the form of a prefilled syringe. For Aflibercept, it's about 95%. So very broadly adopted. But when you look back at what it took to get the prefilled syringe approved, basically the FDA, in addition to some other requirements, had a usability requirement for the Aflibercept prefilled syringe. And this is all publicly available documents that you can search for. But they requested basically a single injection in at least 30 patients to confirm that the performance and quality of the released product is adequate to assure that the labeled dose is reliably delivered. That's a direct quote from their October 2018 complete response letter. And so it's not a big study, but shortly after Eylea prefilled syringes were launched, there were reports regarding elevated intraocular pressure. Patients who had gotten countless injections previously would say, geez, I can't see. And the pressure, people would, doctors would check the pressure. The pressure was high. There are even reports, published cases of transient central retinal artery occlusion related to it. And in Europe, there was a Dear Doctor letter issued in March of 2021, so about a year after launch. And their Pharmacovigilance Risk Assessment Committee cited a 7-fold risk of increased IOP, of intraocular pressure rise, related to the Aflibercept prefilled syringe. And they cited incorrect handling and preparation of the syringe as kind of the root source of the problem. And another way to kind of suss this out is you can actually search, there's something called the FAERS database. I don't know if you're familiar with this, but it's the FDA adverse event reporting system. And we searched that system looking for 3 complications associated with Aflibercept: IOP increase, transient blindness, and ocular hypertension. And when you combine that with another term called device use issue, which really pinpoints the syringe as the problem, they're basically all happened since the 3rd quarter of 2020 and mostly from Europe, interestingly. So kind of the point of the research actually was to look at why do we see this problem with the Aflibercept prefilled syringe and not the Lucentis or ranibizumab prefilled syringe. And I think the reasons are a few. Number one, the ranibizumab prefilled syringe is a 0.5 ml syringe. It's a half ml syringe. The Aflibercept prefilled syringe is a 1 ml syringe. It's a syringe that's twice as large, and so the internal diameter of the Eylea prefilled syringe is actually nearly 2 millimeters larger in internal diameter than the ranibizumab prefilled syringe. Coupled that with the fact that there's a little dose mark where it shows you where that plunger is supposed to line up, and the ranibizumab dose mark is a 1/4 millimeter in thickness. The Eylea or Aflibercept dose mark is 3/4 millimeter. It's 3 times the thickness. So that leads to some just inherent confusion of where along that dose mark do I line up the plunger. And if you just calculate the internal diameter and the thickness of the dose mark, well, that could give you about 4 microliters of variability with the Lucentis prefilled syringe, but 24 microliters of variability on the Eylea, on the Aflibercept prefilled syringe. So the large internal diameter and the large dose mark thickness contribute to these problems. And then finally, both the Lucentis and ranibizumab prefilled syringe have these coned tips. The plunger is not a flat across plunger. It has a little cone to it. So there can also be some confusion of, wait, am I lining up to the tip of the cone, or to the base of the cone? It turns out you're supposed to line up to the base of the cone of the plunger. So we ran some simulated experiments using empty prefilled syringes, both ranibizumab and aflibercept. We used purified water, and we measured the volume by mass using an analytical balance. So we tested kind of multiple scenarios. For Lucentis, we tested the base of that cone lined up to the dose mark, or to the tip of the cone lined up to the dose mark. So 2 scenarios for Lucentis. And for Eylea, we tested 3 scenarios. The base of the cone lined up to the internal edge, the proximal edge of that dose mark. The base of the cone lined up to the distal end of that dose mark, which, remember, I told you is 3 times as thick as in the Lucentis syringe, or the tip of the cone of the plunger lined up to the outer edge of the dose mark. And what we see, and we tested these scenarios multiple times and then recorded the volumes. And what we see is, first of all, if you comply with what they call the IFU, the instructions for use, with both of these syringe systems, they work well. What's the instructions for use? Not the tip of the cone, but the base of the cone lined up to the internal edge of the dose mark. Both were highly accurate. 47 microliters for Lucentis, 54.8 for Aflibercept for Eylea. What else did we find? That dose mark thickness, if you line it up instead of to the internal edge of the dose mark, but rather to the external edge, the outer edge, the distal edge, your average dose was actually 78.9 microliters. So it's over a 50% kind of overdosing of what we normally should be delivering, which is, again, a target of 50 microliters injected. That's just based on the dose mark thickness. It also is nice that comported very closely with our theoretical calculations based on just internal diameter and dose mark thickness. And then finally, if you make the mistake and line it up with the cone tip rather than the base of the plunger, the average volume injected is 109 microliters, which is more than double the intended volume, actually about 120%. So these little things here can make a big difference for our patients. And we think of it as such a simple device. It's a syringe, it's a pre-filled syringe. There's not much going on, but tiny little industrial design factors can actually make a big difference in the care of our patients. And that was kind of the bottom line summary of what I presented at Retina Subspecialty Day.
Is there more Eylea in the Eylea syringe than Lucentis in the Lucentis syringe?
In terms of the amount of overfill?
Yeah.
These pre-filled syringes are designed for storage. So unlike sometimes people get the off-label bevacizumab or Avastin that are filled with a fixed tip needle, where the needle is already attached to the syringe, and that actually doesn't comply with USP guidelines 787 and 789, because those syringes are not meant for storage. If something accidentally hits the plunger, the back of the syringe, you could actually be injecting medication into the cap. So both Lucentis and Eylea prefilled syringes have a method to seal the syringe. There's no fixed needle. You actually apply your own needle to it in clinic. And so there's a little bit of air in the system, and they both are overfilled. But I didn't actually take the time in this study to measure how much they're overfilled by.
Mm-hmm.
Yeah, I know that when Eylea first, in the world of vials, Lucentis had a little bit more overfill than Eylea. And I think that was a reflection of the fact that Regeneron perhaps was concerned, particularly in Europe, that they might split doses and try and extract 2 doses of Eylea out of a single vial as a cost-saving measure. So that the fill in the glass vials is a little bit less for Eylea versus Lucentis, but I'm not sure on the pre-filled syringe side.
So what's the practical advice to the clinician about making the correct dose?
So number one is just honestly, I think this was an important topic just for everybody to know that, wait a sec, I'm supposed to use the base of the plunger, not the tip of that coned plunger. And I'm supposed to line it up to the internal edge, the proximal edge of that dose mark. That's number one. And I think that syringe system rolled out with not sufficient education to the retina community about how to properly use it. Two is I think it's very interesting to think about some of these next generations of therapies that might be coming down the pike, where we're actually going to be routinely injecting 100 microliters of fluid into the eye, or perhaps combining 50 microliters from two different medications. And what are the implications about, a 20% difference or a 50% difference when you're talking now about a scaled up volume could actually have serious repercussions for, the perfusion of the optic nerve. And I think it's important to be thinking about some of these little factors as we introduce new medications to treat retinal diseases.
What about Lucentis?
What about it? What do you mean?
What about using the Lucentis syringe? What's your advice about that?
It's a great syringe. I actually think because it's got a shorter internal diameter, there's a greater excursion of the plunger. So you actually get a little more tactile feedback from the syringe to you actually feel the plunger moving and you're like, okay, yeah, great. I definitely injected medication. Because the internal diameter of the Aflibercept or Eylea prefilled syringe is so much larger, there's very little excursion of the plunger, and you don't get that same tactile feedback to say, oh yeah, I just injected medication. So personally, I actually prefer the kind of, it's not ergonomics, but I prefer the general operation of the Lucentis prefilled syringe. Now, kind of how the IP and patent protection associated with all of these syringe systems works, and the storage of an antibody and what that means, that's above my pay grade, because I'm sure there's a lot of IP around these syringe systems. So part of the reason Regeneron may have made the choices it did may have been to avoid some of the intellectual property that Roche and Genentech had on the Lucentis prefilled syringe.
What's your advice about injecting bevacizumab?
In terms of dosing it properly?
Yes.
So bevacizumab typically comes from a compounding pharmacy with a set dose. And that is true for those people using still the silicone lined syringes, the Becton Dickinson tuberculin syringes. It's also true for, I think probably the most commonly used syringe in the US is the NormJect silicone-free syringe. Now that's still lubricated with another lubricant, which can still get into the eye. It's not a syringe that's designed for, storage of an antibody over time. But those are both pre-filled syringe systems, and they don't come with an overfill. So if you want to try to prime the syringe, you're probably injecting a little bit less medication than intended, than at least a 50 microliter dose.
Well, Roger, thanks a lot for this very enlightening discussion about a common procedure that needs to be done very precisely.
Thank you for having me.